You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about anticoagulant targets after valve replacement. We'll go over anticoagulation targets, anticoagulant choice, interruption and bridging for surgeries, then we'll see what the guidelines have to say about all of this. Let's dive in with anticoagulation targets. Mechanical valves have a much higher bleeding risk than bioprosthetic valves, but they do come at a benefit of lasting longer than a bioprosthetic valve. Even with warfarin, the risk of thromboembolism from a replaced valve is 1 to 2% a year. The goal for mechanical mitral valves is always INR of 2.5 to 3.5 lifelong, whereas the goal for mechanic aortic valves is 2.5 to 3.5 lifelong if there are risk factors, whereas INR 2.0 to 3.0 if there are no risk factors. Why? Because the mitral valve is way more thrombogenic than the aortic valve. The mitral valve replacement, mechanical, has a 2 times higher risk of thrombosis than a mechanical aortic valve replacement. That's why for mechanical mitral aortic valve replacement, the goal is always INR 2.5 to 3.5, regardless of the risk factors, whereas the goal for the mechanical aortic valves replacement is INR 2.5 to 3.5 if there are risk factors, and INR 2.0 to 3.0 if there are no risk factors. What are the risk factors? AFib, LVEF less than 35%, previous VTE, hypercoagulable state, older generation mechanical aortic valve replacements such as Starr-Edwards valve or a disc valve other than Medtronic Hall that have high thrombogenicity risk, or more than one mechanical valve. These are the risk factors that would bump you from an INR of 2.0 to an INR of 2.5 to 3.5 for the mechanical aortic valve. On this note, if a patient has both a mechanical mitral and a mechanical aortic valve, then the target INR is definitely 2.5 to 3.5. Unlike mechanical valves, bioprosthetic valves have a lower risk of thromboembolism, so the requirement for therapeutic INR is shorter in the number of months. The goal for bioprosthetic surgical valves, regardless of mitral or aortic, is INR of 2.0 to 3.0 in the first 3 months, followed by an aspirin 81 daily monotherapy after the first 3 months. There's a special case. The ON-X mechanical aortic valve has a goal of INR 2.0 to 3.0 in the first 3 months, followed by INR of 1.5 to 2.0 after the first 3 months. This is the only major valve where you have an INR goal of 1.5 to 2.0 after the first 3 months. How about for TAVR? For transcatheter valve replacements, which thus far are all bioprosthetic, the regimen is either aspirin monotherapy or Plavix clopidogrel monotherapy for 3 to 6 months. Should aspirin be added in post-surgical valve replacement patients in addition to the warfarin? In the past, it was assumed that all the ones getting warfarin should also be getting aspirin 81 on top of the warfarin, but that is no longer assumed. The default is now not to add aspirin 81 to warfarin. According to ACC, the 2020 ACC-AHA valve guideline no longer recommends routine low-dose aspirin use for patients with mechanical prosthetic heart valves. This is because the prior recommendation to add low-dose aspirin to therapeutic VKA therapy, i.e. warfarin, for a mechanical valve prosthesis was based on studies performed decades ago that included many patients with older generation prosthesis who also had additional thromboembolic and vascular risk factors. There is a 2013 Cochrane systematic review which showed that compared to anticoagulation alone, the addition of an antiplatelet agent reduced the risk of thromboembolic events and the total mortality rate, but at the cost of an increase in offsetting risk of major bleeding. Thus, low-dose aspirin now only has a Class 2B recommendation. They say, for patients with valve replacement who are managed with warfarin and have an indication for antiplatelet therapy, addition of aspirin 75 to 100 milligrams daily may be considered when the bleeding risk is low, Class 2B. What about the ESC? ESC says that the relative indications to add on aspirin to warfarin in post-surgical valve patients are as follows: concurrent arterial disease, concurrent coronary artery stenting, or recurrent embolism. The ESC also offers relative contraindications to adding aspirin to warfarin, in the post-surgical valve plate patients. These are history of GI bleeding, especially with ulcerative disease or angiodysplasia, hyperresponders to aspirin with excessively prolonged bleeding time, poorly controlled hypertension due to risk of intracerebral hemorrhage, elderly patients, especially women above 75 years of age, patients who take multiple medications, require frequent courses of antibiotics, or have erratic INR control. This is the list of relative contraindications to adding on aspirin to warfarin in post-surgical valve patients according to ESC. If a mechanical mitral valve patient has experienced a stroke or a systemic embolic event while being on therapeutic warfarin, then it is reasonable to either increase the INR goal from 3 to 4, i.e. from 2.5 to 3.5 to 3.5 to 5.0, or to add daily low-dose aspirin with 75 to 100 milligrams. Note that in all of the INR targets that I've mentioned so far, even though I'm giving you the bracket, say 2.0 to 3.0, the new standard is to give a specific goal, a number in the middle of that range, such as 2.5, and that way it is more likely for patients, pharmacists, physicians to achieve the middle of that range rather than the edges of 2.0 and 3.0. So just remember that when you're thinking 2.0 to 3.0, you should be recommending a target of 2.5 with a safety zone of 2.0 to 3.0. If you have embolic events while on antithrombotics, if it's a bioprosthetic valve, then upgrade from your aspirin monotherapy to warfarin. If mechanical valve with an INR target of 2.5 with an acceptable range of 2.0 to 3.0, then upgrade the INR target to target of 3.0 with an acceptable range of 2.5 to 3.5, or add aspirin on top of your existing warfarin. If the mechanical valve has an INR target of 3.0, then upgrade the INR target to 4.0 or add aspirin. And when you upgrade the INR target from 3.0 to 4.0, you can give a safety range of 3.5 to 5.0, or you can add aspirin. Now let's talk about anticoagulant choice. Can you use DOACs instead of warfarin? For mechanical valves, never use DOAC. Dabigatran had excess thromboembolic and bleeding risk compared to warfarin for mechanical valves, so they did not study rivaroxaban, apixaban, or edoxaban. They must be on warfarin lifelong. For bioprosthetic valves, if there is a concurrent reason to use a DOAC, such as concurrent AFib, it is okay to switch from warfarin or aspirin to a DOAC. Now, and bridging for surgeries. There are situations where you stop warfarin 3 to 4 days before surgery and have to start either low molecular weight heparin or unfractionated heparin in addition to the aspirin. These are all mechanical mitral valves, mechanical aortic valves that have risk factors, see the list that I gave you above, and all other situations you can stop warfarin 3 to 4 days before the surgery and just be on aspirin monotherapy. When do you bridge for bioprosthesis? Going to other surgery? If there's no risk factors, then no bridging's needed. If it is within the first 3 months or there are risk factors that I told you above earlier, then you bridge. So it's simple enough. How do you bridge? You stop warfarin 5 days prior to the procedure. You begin Lovenox, which is low molecular weight heparin, 3 days pre-op when INR is less than 2.0. The last dose of Lovenox should be 24 hours prior to the surgery. Check the INR on the morning of the surgery. Restart warfarin immediately post-op. Remember DVT prophylaxis if it is off, and whole therapeutic heparin for 48 hours post-op, generally. What do you do for the no bridging situations? You can hold a warfarin for 5 days, obtain an INR on the morning of the procedure, and restart a warfarin immediately post-op. For post-operative bridging immediately after a mechanical heart valve transplant, subcutaneous prophylactic dose unfractionated heparin or low molecular weight heparin at either prophylactic or therapeutic doses are better than therapeutic dose unfractionated heparin until the INR is stable on warfarin therapy. Now, let's recap the above information by seeing what the 2020 valvular disease guidelines say about anticoagulation targets. Let's start with the mechanical surgical valve replacements. In patients with a mechanical prosthetic valve, anticoagulation with a VKA, such as warfarin, is recommended. That's a class 1 recommendation. In patients with a mechanical bileaflet or current generation single tilting disc aortic valve replacement and no risk factors for thromboembolism, anticoagulation with a VKA to achieve an INR of 2.5 is recommended, Class 1. For patients with a mechanical aortic valve replacement and additional risk factors for thromboembolism, such as AFib, previous thromboembolism, LV dysfunction, hypercoagulable state, or an older generation prosthesis such as ball and cage, anticoagulation with a VKA such as warfarin is indicated to achieve an INR of 3.0, Class 1. For patients with a mechanical mitral valve replacement, anticoagulation with a VKA is indicated to achieve an INR of 3.0, Class 1. For patients with a mechanical surgical aortic valve replacement or mitral valve replacement who are managed with a VKA and have an indication for antiplatelet therapy, addition of aspirin 75 to 100 milligrams daily may be considered when the risk of bleeding is low, Class 2B. For patients with a mechanical on-X aortic valve replacement and no thromboembolic risk factors, use of a VKA targeted to a lower INR, 1.5 to 2.0, may be reasonable starting at least 3 months after surgery, with continuation of aspirin 75 to 100 milligrams daily, Class 2B. For patients with a mechanical valve prosthesis, anticoagulation with the direct thrombin inhibitor, dabigatran, is contraindicated, Class 3, harm. For patients with a mechanical valve prosthesis, the use of an anti-10A direct oral anticoagulant has not been assessed and is not recommended, Class 3, harm. Let's listen to what they have to say about bioprosthetic surgical valve replacements. For all patients with a bioprosthetic surgical aortic valve or mitral valve replacement, aspirin 75 to 100 milligrams daily is reasonable in the absence of other indications for oral anticoagulants, Class 2A. For patients with a bioprosthetic surgical aortic valve replacement or mitral valve replacement who are at low risk of bleeding, anticoagulation with a VKA to achieve an INR of 2.5 is reasonable for at least 3 months and for as long as 6 months after surgical replacement, Class 2A. What about after transcatheter valve replacement, like TAVR? They say, for patients with a bioprosthetic TAVI, aspirin 75 to 100 milligrams daily is reasonable in the absence of other indications for oral anticoagulants, Class 2A. For patients with a bioprosthetic TAVI who are at low risk of bleeding, dual antiplatelet therapy with aspirin 75 to 100 milligrams and clopidogrel 75 milligrams may be reasonable for 3 to 6 months after valve implantation, Class 2B. For patients with a bioprosthetic TAVR who are at low risk of bleeding, anticoagulation with a VKA to achieve an INR of 2.5 may be reasonable for at least 3 months after valve implantation, Class 2B. For patients with bioprosthetic TAVI, treatment with low-dose rivaroxaban 10 milligrams daily plus aspirin 75 to 100 milligrams daily is contraindicated in the absence of other indications for oral anticoagulants, Class 3, harm. So we've gone over anticoagulation targets for mechanical, surgical, bioprosthetic surgical, and transcatheter bioprosthetic valves, anticoagulant choice, interruption and bleeding for surgeries, and we've gone over the pertinent abstracts from the guidelines on the valve disease from 2020. That's all for anticoagulant targets after valve replacement.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.